and we'll get started. So thanks all for joining. I'm Jeff Taylor with the HIV and Aging Research Project, and this is one of several community town halls we've been doing. Lately, we've been doing them every other week because there's so much happening. So we're delighted to have you all here, and especially our county and state public health officials and our providers will be providing updates. So start it all off, let me post in here as well the White House's announcement that they are going to be approving a splitting the doses, so getting 5 doses out of one vial, which was previously a single dose, and administering that not as a shot in the arm, but as a into the upper layer of the skin, intradermal injection, they call it. And I'm sure they can tell us more about that. And I know people will have some concerns. There's not a lot of data, but it looks promising enough that the FDA has done this and the White House has announced it. So why don't we just get started with the county, and you can tell us what's going on. Who wants to go first?
I wonder if I could start with talking about the intradermal and then switch over to Misty to provide a county update. And that's what's why I'm smiles this morning is because, or today is because once I heard about that potential of splitting the doses and having more vaccine availability, the hope with that is so great that we could use one dose that would typically be for one person to potentially for 5. So right now where we are is we're waiting to hear from CDPH on their guidance around the intradermal use. But in the meantime, I've already been making calls, seeing, what we're hoping is that I was thinking our TB providers, they do the intradermal injections for the TB test. And so they already know how to do these intradermal injections. They can help us with, providing that education to the other nurses, get everybody up to speed quickly, such that once CDPH gives the thumbs up as well, that we can start moving towards that direction. And it also opens opportunities for what that might mean for our prioritization and what that means for being able to have events. I'm sure these are all things that people are thinking about as well. And it's all things that we are thinking about too, is, the thumbs up on that, what that can mean in terms of us being able to get vaccine out to larger groups of the community. So I guess that we'll start there. And then I have a couple of other updates, but I'll shift it over to Misty first to give the global update, and then I can add some things after that.
Great. Thank you, Dr. Shvinsky, and good evening, Jeff and group. Happy to be with you this evening. Since we've last met, but just a generalized update as well, we are in phase 3A for allocation of vaccine through CDPH. Riverside County Public Health received 1,120 doses of vaccine. That's our threshold allocation. The allocation piece was supplemented by an additional request from the Public Health Department for 1,500 doses. That additional allocation threshold was denied, and an alternative of 750 doses was provided by CDPH. We're anticipating delivery of that additional 750 doses likely this week into the warehouse. We have, with all of our providers' support, expanded the vaccine providers to include Riverside Medical Clinic, as well as we've expanded to add some additional referral support within RUHS EIP, and we'll be working with other urgent care and clinic providers to facilitate direct referral for patients. The system goes to supplement existing providers with Borrego Health, DAP Health, Eisenhower Health, as well as Kaiser and our early intervention program, as I mentioned, with RUHS. The 1,120 doses will be similar allocation path as before. 75% will go out to providers. We'll try to push up to 80% as best we can, and then we'll retain for public health to continue in-home post-exposure prophylaxis. Our mobile teams continue to host both in-home post-exposure prophylaxis to support the community to the tune of approximately 15 to 20 doses a day through the referral process through healthcare providers, as well as through our public health disease control referral network. And then we are working also with this next allocation and the news that you've just shared, Jeff, and Dr. Shavinsky has elaborated on to potentially expand prioritization groups. Current vaccine prioritization is inclusive for very selective healthcare worker prep, laboratory worker support, and then gay, bisexual, transgender, non-binary persons, and cisgender men who have sex with men with a recent bacterial STI infection, syphilis or gonorrhea. We have also done strategic outreach with several of our partners, including many on this call, to reach the sex worker community, as well as individuals who work or volunteer at a sex resort, sex club, bathhouse, or sauna. And future prioritization groups will expand as the vaccine supply would allow. I think the other piece that I would provide with the vaccine allocations is we work with providers to do additional allocations Tuesday or Wednesday of each week based upon the CDPH supply that comes in. And I think that's, I'm going to pause there and see if that generates additional questions or need for clarity.
And if not, I can add on to a couple of other updates as well. Okay, so I also just wanted to share our director, Kim, testified today about monkeypox. Oh yeah, I did it. I don't know if other people saw that, but advocated in terms of the additional need in our county, talked about the cost of lab tests, which is something that we've heard echoed on this call multiple times that she raised up as well, talked about lab capacity, talked about funding, and so advocated on behalf of our community to get additional resources. So I just want, in case people didn't see that, wanted to call that out. On this call, many people may already know, but also wanted to share our public health officer, Dr. Leung, signed the declaration of a public health emergency as well. And so I wanted to make sure everyone on the call was aware of that too, in hopes that it can foster additional collaboration as resources become available, that we be able to quickly and effectively get them, utilize them. So in preparation of what there might be to come. And then I know some people on the call already started to see our video updates that we've been doing each day. That was in reflection of comments that were made on the previous calls. And I will mention, I hope I don't embarrass him, but David specifically had called out of the kinds of information that would be very helpful to include. And so we've tried to make an effort to model ours in terms of having the high yield information about vaccine, about other key updates that we want the community to know, including about the vaccine interest form. And so I do want to share that the vaccine interest form, that we've gotten a lot of use out of that. So Misty might have exact numbers, but the last I saw was over 930 responses on that, which is fantastic because especially now, if we're able to shift to the intradermal as we find out more about vaccine doses, we have a pool of people that we can contact, schedule, etc. So that has proved to be very helpful so far. Appreciate those that have been spreading that. I'm sure others on the call have helped with that, but I sent it out on Instagram to a few influencers who I know are posting about monkeypox vaccines. And so had some nice conversations with them and their interest and ability to help us further with also other kinds of social media strategies and getting the word out. So I'm hoping that also helped with that effort. And then one other update that I just wanted to provide is that the CDC put out a resource for treatment for people with monkeypox that also have HIV. And so it talks about management strategies and how to, they include also a checker on checking the antiretrovirals or other medications to make sure that there wouldn't be an interaction with TPOXX. So I can put that resource in the chat as well. I've been incorporating it now into presentations to healthcare providers, but I'll include it here too for any healthcare provider that's on the call, or for the community, for people to be aware that, if that comes up with your healthcare provider, that you have the resource. So I'm going to put that in the chat right now.
We can't hear you, Jeff. You're muted.
Oh, I'm sorry. Thank you. I was saying that there have been a lot of questions coming up in the chat about the new dosing strategy, splitting the dose and doing it intradermally. I was wondering if any of the medical experts would like to speak to that, about the data, and if there are concerns about special populations like people with HIV, either suppressed or not suppressed, older folks. What about people who've already had the smallpox vaccine? Would they need a second shot at all? Would this be effectively a booster? So things like that. So
I
anybody
can
like
start
to,
on that. I can
Yeah.
start. Since information has been started to put out, I've been reading as much as I can. And so this is based off a study that was conducted in 2015, and it was a non-inferiority study. So looking at comparing if you are giving the vaccine the way that we typically do versus the intradermal. And what they found was that it wasn't inferior. So if they did it with the intradermal, that it appeared to have similar results. I could post that study in the chat as well. And it's been updated just today on CDC as well, where they're talking a little bit more about the dosing strategy. Some of the things that were helpful that what I was, that I thought, will help in our response is that if their first dose was the regular way, they can still get the second one intradermally. There's no problem with that. Right now, the guidance is for adults, so 18 plus, but it doesn't give specification yet in terms of, if there's somebody who's immunocompromised or older. I have not seen anything yet on that. Just for pediatrics, for kids, that they would still get it the regular way. They wouldn't get it the intradermal way. But I'll put those resources that I've been reading through in the chat in case it's helpful for others as we read through. So I'm going to work on getting some of those in there. But if there are other providers on the call that have read other information that they want to add in, please feel free.
Yeah, Dr. Kirkard just posted, if you could clarify if someone who has recovered from monkeypox needs a vaccine, and if they need it or not, and if yes, then when. So when does it provide
Sure.
sterilizing protection is the question.
So the current guidance is if somebody had monkeypox, that they would not be getting a vaccine. So even if, say, they got their first vaccine, then they developed monkeypox, if the question is, should they get the second vaccine, the answer would be no. Or if they just got monkeypox, then it's considered to have developed immunity such that it would protect in the future. With that said, there's still studies being done to understand what the length of protection is for somebody who's developed monkeypox, or similarly for the vaccine, how long that protection will be over time, and whether there'll be some level of waning. So that is more to come.
Yeah, a lot more research needed. And I was on that Senate hearing today as well. And in the comments, I suggested that we use our great world-class research facilities here, funded by taxpayer dollars, to do exactly that kind of research in real time, because just like it did with HIV, it's a great way to both provide access, people enrolled in the study, they get the vaccine, and then we get data on those specific populations that we don't have any data in yet. So hopefully that will happen either at the NIH level or locally, or both. There's one other question, and maybe a Jennifer or Misty question about how privacy is being protected with the vaccine information form. They have a knee-jerk reaction that this is a lot of personal information to be sharing. So if you could address that.
Sure.
Dr. Stravinsky, go ahead.
So well, Misty, you can certainly add on, but one thing that we did to try and protect additional privacy, it was fed back information came to us early on that with an office form, if it's not embedded in actual link, that there could be some security concerns of people making a mock-up or something that mirrored it. So we embedded it in the website such that it would be it wouldn't be able to mirror it with the same website link. Like it wouldn't just be an office link. So that was one thing that we did to try and additionally protect security. So what we recommend, therefore, is to only fill it out on the embedded web page rather than through the doc. So that way you can be certain that it's a Riverside County form that you're filling out. And then in terms of additional protection, I could switch it over to Misty.
So I would add, we did get community feedback that there was concern, Jeff, also, and could potentially be the same feedback that's being issued here. We really appreciated the insight there. We navigate PHI through protected server systems that are password encrypted, and only individuals in the public health department that need to have access to that data to help with vaccine scheduling and similar are having access to it. So it goes very specifically into the immunizations and emergency response branch of public health. And then we activate through it with our scheduling team to assist. And so it's password protected, credential protected, not published anywhere else. And then it's routinely downloaded through our IT security processes off of its storage location, so it doesn't live there either. So hopefully that helps with some of the questions.
Great, thank you. And I see John Taylor has a question. Go ahead, John.
Yeah, I was looking at the online interest form and talking to lots of people that have had the monkeypox shot through invitation only or through a web of lies that they told to get in and jump the line. And what is the threshold of available vaccine that will allow people to individually decide that they want to get the monkeypox vaccine rather than have it decided by a invitation committee or by text messaged back channels of chicanery?
I could start on that one and Misty can perhaps add in. So when we initially were forming the criteria, it was based off of the CDC guidance, the CDPH guidance, and then in addition, the conversations that we had on the town hall and the community meetings about who was considered to be at the topmost highest risk. So that was the idea behind those, knowing that we had very limited supply and a lot of need. With that said, the hope is exactly that as we expand to intradermal, if that is something that's approved also by CDPH, that it will also open up the ability to expand prioritization and move closer in that direction. But we'll need more guidance from CDPH and from CDC as to when we can start to do that in order to help shape our ability to expand out in prioritization. If there are specific groups, we've been taking feedback on this call of people that we should be considering in the highest risk tiers. With that said, that is not meant to mean those are the only people at risk, because we know that's not the case. We know that there's elevated risk in many groups that are beyond what's currently in the prioritization initial category. It's just the tip of the iceberg. And so our hope is that with the vaccine doses that we can expand and reach all of those that are at elevated risk based on the criteria that we know it puts people at elevated risk. One of those things is having multiple sex partners. Now that's something that somebody individually can identify for themselves. Many of these things are things that people can individually identify for themselves. So we're hoping as we get more doses that we can move closer to that direction.
Great, thank you. So I know there's some questions coming up in the chat and maybe people can take a look at those and respond if they can. I do want to give the folks from the state a chance to talk about what's happening at the state level. You keep saying if CDPH does this or that, they might have some input on that as well. So I don't know if Marissa Ramos or someone else from the state would like to unmute and chime in, give us an update from their perspective.
So right now, I know it's brand new, so we are looking at the policy and how we're going to roll it out in California. So that's all I could say is as everyone heard today, we also heard, so more to come. And we will be working with the counties to assess how we could assist them.
So stay tuned.
Stay tuned, yes.
Thank you. Yeah, I know this is all kind of breaking news and a lot to be done, but you know, people were saying if it gets approved, I think it's not a matter of if, but when. Is that right? Since the CDC is, the feds have signed off on it.
Correct.
Yeah.
So now we just have to assess how it would roll out in California with the, and of course, consultation with all the different local health jurisdictions.
Right. Great, thank you. And I know we want to give time for our providers to talk about what's happening on the ground, but I think David had a something he wanted to say. Go ahead, David.
I know that some of the stakeholders in this meeting have received the email from me and probably talked about it in the past, but I did want to go over it in this public forum and present it in a way that the community can see at large what I'm asking for. And it's very important. Am I able to share my screen?
Yeah.
Oh,
should be.
Let's see if I can do this. Uh-oh. Okay. There we go. Oh.
And if you have trouble, you can email it to me and I'll put it up.
Jeepers. Well, I tried to share my screen and now it's telling me that open system preferences. All right. So I don't know what that means, but sorry. 8, 2, 3, 4, 3, 0, 8. There we go. Quit and reopen. You probably have to come back to me. Sorry.
Oh, no worries. I see other hand up, and then we'll move under our providers. Vincent, go ahead.
Yeah, thank you very much. This is for the healthcare providers. Is the shot that you received, you know, the 2-dose, however it's administered, is that a once in a lifetime shot that we'll be receiving, or is this something going to be like perhaps maybe like COVID or other immunizations where we may have to get, you know, repeated shots year after year until this comes to some type of a cure or something continues on with this?
I can start on that one, and if anyone wants to add on. Right now, the current recommendation strategy is for the 2 vaccines. However, I think as Jeff mentioned as well, the hope is that there'll be additional studies to see if there's any level of waning of immunity, and whether long-term there would need to be some kind of booster, or at what time interval that would make sense. The reason that I mention that is because with the smallpox vaccine, for instance, there are people that had that when they were younger. And what we see is those that had it when they were younger, for those that are over the age of 50, for instance, that might have gotten that, you know, when it was still happening here in the US, that there are some number of people that still go on to get monkeypox. And the recommendation currently is if somebody had received a smallpox vaccine more than 3 years ago, right, and then gets exposed, that they still would be eligible for post-exposure prophylaxis, which means that there is potentially some level of waning from the vaccine. So what we don't have right now is information about how long or when there would be some level of a booster or a repeat dose, if that would be needed. And so that's where I think, you know, we're mentioning the studies could help us to see whether that's, you know, that it'll be 2 and then that's it, or at what point in time afterwards might we need to have additional booster doses.
I think in the past it's recommended who are high risk exposures, people who work in laboratories, who work with monkeypox or smallpox, they get the vaccine every 3 years. Now, hopefully we're not going to be dealing with this like COVID 2 years from now. So hopefully nobody's going to need another booster at that time, but it doesn't give lifetime immunity. So it'd probably be another vaccination in 2 to 3 years if this is ongoing.
Well, and also I've read that it's a lot more stable than COVID. It's not constantly mutating in the way that COVID is. So they don't think we'll have to keep coming up with new versions like we have with COVID or the yearly influenza, knock on wood. So, great. David, are you ready? Go for it.
Let's hope I'm ready. And I probably don't even need this to share the screen, but I just need it so I could keep track of myself. because I want to talk a little bit about a proposal that I wrote and shared in, I don't know if this is going to work. Yeah, maybe this
Yep,
does work.
perfect.
Great. And so I shared like a really rough draft in an email and added a bunch of people from the stakeholders, community, public health officials and stuff about getting vaccine clinics open and running and it was really brilliant. Somebody came back to me, and I keep hearing this conversation about vaccine equity. And I want to talk a little bit about that because I think it's really, really important. But because we're talking about all of this stuff that's going to be happening in the future and when more vaccine arrives and all of this stuff. But I really want to talk about what's happening in the next 4 weeks. And one of the things that is really important that we all know that's happening is that Gay Pride is coming, Leather Pride is coming, and we're still doling out vaccines by invitation only and to only high-risk groups. And my proposal is that community stakeholders and or the county director create a proposal and submit it to the CDC. I know you've been talking to the CDC every week. I know you've been asking for more vaccine constantly, but I think we can take a more direct approach specifically towards these two particular events, which are going to bring tens of thousands of people into the Palm Springs area. We can even enlist on Jeff's recommendation, Demetrius Daskalakis, in partnership with Representative Ruiz. If Erin's on the call, I'm sure she'd be happy to assist. But we need to enact like an emergency style statement, highlighting our upcoming events and a need for additional allocation specifically about these two events that are coming within 4 weeks. And a lot of feedback I keep hearing is that we ask for something and we only get half. So we need to go in expecting to get half of what we asked for. So in other words, let's ask for double. We have to get creative. My idea is to do 300 doses per day. I'm dubious that we'll get a line of 300 people a day, maybe on a Friday, a Saturday, and a Tuesday, and utilize county health, mobile screening nurses, 2 screening nurses and 2 to 3 vaccine nurses. The location, it's very important that it's accessible and welcoming to all high-risk persons. A public information targeting the most at risk are currently of people who are currently being infected. And this is something I really want to highlight here because it's really important that while in the future we need to dig under every crevice, go into every single person that we think may be at risk for monkeypox, we have to really look at over the next 4 weeks, the people who are actively being infected right now. And 97% of those people are gay men who have sex with men. They're trans. Most of them are people of color. We need to be inclusive of that, but keep and be mindful that this is the impact that we're looking out for in this very next few weeks that is really important. We can collaborate with organizations of Leather Pride and Gay Pride and utilize their mailing list to get the information out that the vaccine clinics will be open and operational for people at risk. And I took this right out of the email because it was a beautiful response that I got back from Tony about all of the people who are invisible, all the people who don't want to go to a sex club and don't want to get their vaccine surrounded by gay men and may feel stigmatized. And so I really wanted to be mindful of that, but I also want to put a few questions out to the stakeholders and county and especially the state about what's happening and how do we reach them and give them a way to have a shot right out of the email. And what I want to know is, how are we not reaching them already? Who has the data and what are they doing with it? And can these big 4 organizations, Eisenhower, DAP, Borrego, the county and Kaiser, can they reach them? Do we have that information? Or is there only room for their own patients? And that's what's been happening a lot is there's so many high-risk people in the big 4 that there's no room for outside entities and the people who are invisible. And can the county reach them? And lastly, I'm just going to restate this again, is that 97% of cases are men who are having sex with men, MSN. They're currently they're being infected right now. So I find it really, really important that we try to avoid slow walking ourselves to an epidemic in the desert in the name of equity, which is actually destroying equity. One high-risk vaccine at a time, cold calling from a list is only useful if we can do both. And by both, I mean we can open up a vaccine clinic for visible high-risk men that have sex with men and reach the most vulnerable, often left out in safe and inclusive spaces, even possibly writing multiple proposals. Time to meet the need of the community. And I mean that in a way that we could be doing, but we have to be doing both. It's really important that we're talking to the men who are currently being infected. And one of the anecdotal things I want to add here is that yesterday morning, I got a call from one of my clients. And as most people know, I'm a sex worker, and my client told me I have monkeypox and I've had it for 2 weeks and I was afraid to tell you. And I remember having a conversation with him because he pays for sex. He has multiple sexual partners. He is high risk. And him saying to me, no, I just want to wait my turn. There are other people who need that vaccine before I did. And sure enough, 2 weeks later, he's infected with a severe case of monkeypox right now. So I know that we're all doing a great job. I know we're all care very deeply for this community, but I want to focus and bring attention to the fact that in 4 weeks or 8 weeks, I think it's 4, I don't know. At the end of October, we're going to be in big trouble if we don't have the men having sex with men in this community right here, protected, at least to the best of our ability with vaccine. And thank goodness there's more vaccine coming. But if we don't have them protected, I'm going to stop sharing that. If we don't have them protected, people are going to get infected and they're going to go back to, or they're going to come from Chicago or Poughkeepsie and bring monkeypox here, and they will get it. And so it's really important that we kind of quell this while at the same time being inclusive. But I see a lot of we have to maintain this vaccine equity in order to vaccinate the most at risk. But are we not paying attention to who's being infected right this very moment? So that's what I'd like to say. I know that there's a lot to be said about that, but I just want to make it drive the point home that this is a time sensitive, possible emergency situation. And if we don't get in front of it and we don't start opening up the doors to vaccinating as many men who have sex with men, trans, Black, white, Latin, Asian, all demographics as quickly and as efficiently as possible, we are going to have a lot of members of our community suffering in agony and pain, and doctors suffering in agony of filling out 2 and 3 hours worth of paperwork trying to get them TPOXX. And so we can do a good job at getting in front of this if we do both. We have to pay attention to what's happening right in front of us and what's happening on the greater scale. So thank you so much. I'm sorry it took me so long to get to that. That's the best I can do. That's what I have to say. I'm actually leaving the country for a couple of weeks, and I really want to be on board while this thing is rolling out. So I would love to get started writing this proposal as soon as possible. So reach out to me if you need suggestions or if I can help you in any way at all. Have a great one. Thanks for letting me talk.
You're on mute. You're on mute again.
Sorry about this. You'd think I know by now. Thank you, David. A couple of people had their hands up, but I'll let Dr. Chavinsky respond first and then go from there.
Oh, I mean, if other people had on that topic, I realized I was the last one to have my hand up. I saw Dr. Ritchie and Dr. Dorsey had it before. So if theirs is on the same topic, I'm okay with them going first, and then I can sort of share.
Dr. Ritchie is shaking her head. Go ahead, and we will get to everybody. We've got plenty of time.
Okay. So I really enjoyed the presentation. So first off, David, if I could get a copy of the presentation, I don't know if you have it uploaded somewhere, or I know that we have your contact information, so we'll reach out for that. And I do want to share that we've been having conversations in public health about the ideas that you have suggested about, events and how we can balance the invite only events that are targeting specifically high equity need areas. But I guess what I wanted to do is throw that out for the conversation, is if we have the limited doses and we don't switch to intradermally versus if we switch to the intradermally and we have more doses available, if we say, a hypothetical of say 500 doses or something like that, that we would have, what does that balance look like to the people here in the community in terms of reach out to specific groups versus first come, first serve, which may mean that some individuals may not be at the highest risk tier. And so I that's more of a question. So
Can I just interrupt you really quick? I'm so sorry. I really want to clarify something really important here. This isn't about the vaccine allocation that we currently have. This is about writing a separate, very specific, important emergency declaration. I don't know what you call it. I'm not a political figure who speaks to big people. A very separate, trying to get more doses just specifically for our upcoming 2 events that are going to create a public are going to exacerbate an already exacerbated public health crisis, especially here in the desert. That's I hope I was clear in my presentation about that. And if not, I stand corrected, but that's something it would be very distinctly separate from the allocation that we already have, and utilizing our contacts with Dr. Ruiz and Demetrius Dakalakis and so on. There's more, but I hope I was clear about that. If I'm not, I apologize.
Thank you. Yes, so that's that part I wasn't sure, because we do ask for additional allocations for specific events. So it sounds like it may be one of those, what you're suggesting is one of those special allocations, or some other kind of proposal with a special allocation asked, where we would be able to balance both doing the typical pathways that we're doing right now to try and reach into deeper into the community, but then also a very more like guided based on this additional allocation in preparation for those events. So yeah, I would love to know what other people think.
Lots of support in the chat, and I don't know if we want to take a informal vote with thumbs up, we can do that. So while we're doing that, Dr. Ritchie, I think you were up next. Go ahead.
Yeah, I just want to say that everything that David said, I 100% agree with. And I was at that Senate hearing today too. And Dr. Chvinsky, you know, I think it was San Francisco. I may be wrong. It was my head was getting boggled. It was long meeting, but I think it was San Francisco that has a bunch of pop-up clinics, and David bringing up the point that people don't want to necessarily go into big clinics and have them see them. If, you know, my clinic doesn't say anything in the front of it. People are happy to come because there's no stigma associated. All we've gotten praise from the Latinx community because of that. And we're having a hard time. I've left it up to my associate medical director to fill out the CARES form, and we just can't do it. And with this emergency statement, I'm wondering why that can't be streamlined. Have you guys come into our clinic and give the monkeypox vaccine if that would help. But really, we have the perfect setup for Latinx, for everyone to come in. That's number one. Number two, did you ever, I don't know if you do this, I just am not sure, but a lot of restaurants, a lot of pop-up restaurants on Twitter, they say, hey, you know, we're here, we're there. Do you guys do that so people know where extra vaccine doses are? Because that might be also a good idea if there are any extra vaccine doses. So those were my two comments.
Great, thank you so much, Dr. Ritchie. If anybody wants to respond to that, I know Tony has her hand up as well. So go ahead, Tony, and then Dr. Barber and John Taylor. So Tony, go ahead.
Okay, so first going back, in the point that David raised of all of the invisible groups, something that's important to keep in mind is that the high-risk populations we're attempting to reach also include members of those invisible groups. That's the primary focus we have to keep in mind. If we're trying to reach the highest priority people, we have to find a way to get into those invisible groups. And that does include the Latin population. If we don't achieve that depth of coverage, we're going to continue to see the spread. We're going to see it go out, and it won't be visible. It won't be reported, and it will be really, really ugly. So there is that. Have we seriously considered doing small vans to reach out? I mean, I know that as an example, we know that we have some people within the community who are deaf, who are very, very active in working with the deaf community. I don't know if they've actually been here. I haven't seen the person I'm thinking of, but that's a community that may not be aware that is at risk because the normal channels we all focus on are there. We also deal with a population that comes into the Coachella Valley from a very rural area and may not be aware of all kinds of things, you know, because they're busy doing their stuff and they're only coming in for, you know, to go see David, I guess. But they may not catch anything. And some of those people do go to PS Test, which is the clinic that was just mentioned. And there is a truth there in, is that me? That better not be me. Okay. There's all kinds of factors that we have to keep in mind when we're doing this. And that's the real key. The catch is if we only focus on the broadest base, we're not going to get those tiny minorities that can become clusters that then become massive events. And the last point, going back again to David's thing, is Pride ends with Palm Springs Pride. I mean, long before I came to California, that was the rule. It started in San Francisco and New York and ended in Palm Springs. And there are people after almost 3 years of nonstop COVID that I know are planning. My understanding is even the airport is staffing up for it because they're expecting it to be far bigger than it was 3 years ago. So it's really important that we have doses in the region available that aren't necessarily assigned to as was described, one of the big four. And I did not say that for anybody else from Borrego. But we need to make sure that they're there, that we can get those doses where people are, as opposed to trying to draw the people to where we want to put them. So this is, it really comes down to, this is a test of our public health system regionally more than anything else. We, there is the whole, for those of you who have HBO Max, there was a whole article on it, a whole show this weekend on, John Oliver did it, specifically on it. And it was not terrible. So it's worth looking at, but that's, we all know you're underfunded. We don't care because we're dying.
Thank you.
That's all.
Okay. Dr. Barber, go ahead.
Now, one of the groups I'm not sure we're going to reach out to them is the people in the community, MSN, who are using meth, because that's been a problem. I had one person who actually we've been trying to reach out for the last 3 weeks to get a vaccine. He never answers his phone. And he comes in the end of last week and lo and behold, he has monkeypox. So it's just this community, we need to find some way to reach out to them. I'd say probably half of our confirmed cases have been in patients who are MSN or using drugs. So I don't know how we reach out to that community and stuff. We try to with phone calls and stuff, and it's not answering. So that's something we need to work on. The other thing is our clinic, we're really stressed right now after COVID and stuff, budget cutbacks and stuff. If I could probably talk to people at Borrego and give you offices in Coachella, in Palm Springs, Desert Hot Springs, if you could provide staff, if you want to have a pop-up clinic at one of our locations, we can provide that. We have 12 exam rooms at our clinic in Digital City. We could give you 3 or 4 exam rooms to use for a day for our clinic if you want. So we just, I have 2 MAs to do all the work. My 1 MA is calling patients, remind them to come in and get their vaccines. She's giving vaccines. She's faxing paperwork to Barbara Cole. She's faxing paperwork to the CDC, and she's seeing she's rooming my regular patients. So we just don't have the staff to deal with on top of a regular medical clinic, vaccination clinic, and treatment clinic. So if we could take one of those things off our hands and help us with the vaccinations, that'd be greatly appreciated, and we can provide the rooms for you.
Dr. Barber, it's Misty. Thank you for that. And Dr. Ritchie, I also heard you loud and clear with venue hosts. So it's great. I really appreciate it. And we will definitely explore further, and we can capitalize on those opportunities. I appreciate it, Dr. Barber. Thank you for bringing that up. And also Dr. Ritchie.
Yeah, and in regards to the meth using population, there's several good suggestions in the chat about reaching out to them. You have to do it one by one on the dating apps, CMA, groups like that. But yeah, they're always, the group that is kind of the vector for all STIs and now monkeypox. So thank you for elevating that issue. John Taylor.
Also, if one thing,
Go ahead.
if that can be added to the treatment guidelines for getting the vaccination, so a lot of patients who are patients who meth are on doxy for prophylaxis. So they haven't had syphilis or gonorrhea in the last year. So if we could add MSN with a history of meth abuse, MSN who are on doxy prep to this guidelines, that would be able to reach a lot of patients and stuff that we're not right now, don't fit the guidelines.
So those guidelines, that's a good point about doxy prep. Can the county add that to theirs independently, or does it need to come from the state? I mean, ideally it would be both, right? But hopefully we have the leeway to do that here locally.
Yeah, Jeff, it's Misty. I think we'll take it back to both, actually. We'll bring back to state groups to discuss the risk. And I'm sure we cannot be the only health jurisdiction that's experiencing that same type of risk. So I think we do both. We consider through some clinical judgment and risk, taking the feedback from this group. And then we also work with the state to have that factored into additional considerations. So we'll continue that advocacy through these channels and take that back to our team as well.
Great, thank you. I know that came up on the state Senate hearing today as well. So you're right. We're not the only ones thinking about that. Sean and then Henry. I know Henry has to leave at the top of the hour. So
quick question. Jennifer, Misty, how many doses have been requested and denied to Riverside County? I'd like to know the number so I can tell our audience. I have 48,000 ears who are gay men who are having sex with men. And I think they would be interested to know how many doses have been requested by the county and subsequently denied by the state of California.
So taking into account vaccine supply, 2,400 have not been able to be fulfilled with the existing inventory that had been received by the state at that moment in time. They've been deferred for future allocation, or we've been requested to ask again at a later time, which we do, but that's the number.
Can I use denied? It sounds stronger.
So I'm quoting back,
angry.
I'm quoting back the verbiage that was sent to me.
I'll say denied. The state says deferred. Either way, the answer is no.
Either way, the answer was no to 2,400 doses. I will say that, yes.
Thanks, Misty, for that. And a lot of people are talking about how little transparency there is. And I know you guys have been pretty damn see-through. And I appreciate everything you do.
Thank you. Henry Nosovitsky, go ahead.
Thanks, Jeff. Yes, thank you so much. I really sincerely appreciate everyone's advocacy for the vaccination effort. I do want to turn the attention to testing and to treatment on the testing front. So for diagnosis, in the initial rollout of LabCorp's testing, the turnaround time was approximately 48 to 72 hours after the receipt of the specimen. Currently, we're running at 7 to 8 days. One of the things that I'm wondering if the county as well as state, and if anyone is on the line from the federal side, is to advocate for increase in the testing capacity, not in terms of the number of tests, but the rapid turnaround time. Just because we can allocate an increased number of testing and offer it to the, to the public, to run those tests, it does not mean that the turnaround time in a diagnosis is crucially important. Every day that you waste is a day that you don't have spent on contact tracing and so forth. So I think that's a really important point to bring back to HHS as well as to FDA and CDC. On the second point of treatment, so difficulty in accessing treatment has been one of the major topics of discussion. And for those patients who have been diagnosed with monkeypox, it could be a pretty significant debilitating disease. And so access to testing. So as a background, one of the things that in the last, and Dr. Ritchie can attest to this, is that I've been advocating in the last 3 to 4 weeks to declare MPX as a public health emergency, not on a state or a local level, but on a federal level. And the reason for that, which has been done, and the reason for that is because it opens up, declaring a public health emergency opens up a wide range of options for the federal government. And that includes authorizing TPOXX or tecovirimat for the treatment of monkeypox under the emergency use authorization and not under the current EA IND, which is the expanded access. Currently, under the expanded access, and as termed investigational new drug, is that there is an inordinate amount of paperwork that needs to be done. And that is incredibly time consuming, and not all clinics can do that. And so right now we do have TPOXX available to us at Borrego, but the amount of cumbersome bureaucracy and red tape that requires to go along with that is incredibly challenging and debilitating. So I would like to ask our local, state, as well as, most important, our federal partners, if Congressman Raul Ruiz's office is on this call, is to really push Health and Human Services, FDA, along with the CDC, to move forward in what they did with Paxlovid, what they did with molnupiravir during the COVID outbreak, is to declare, is to classify TPOXX under the emergency use authorization. If that happens under the EUA access, that will allow to bypass the bureaucracy and the red tape, which would allow expanded access of TPOXX from the strategic reserve, because we do have a huge supply in the United States, is to allow it to be available at CVS, at Rite Aid, at other pharmacies. And what I want to do is, I do want to stress this point. We need to really, really go back and learn from our previous pandemics, as well as epidemics. And think, for those of us who are old enough to remember MRSA, about, in the last 20 years, what happened was, initially it was high in the MSM community, but very quickly it spread into high contact sports, and in high school, wrestling and band and other general population communities, is that this is not going to be confined to the MSM population. And I'm already getting calls from our pediatricians and our other sites, and then they're already starting to see patients who are pediatrics with suspected monkeypox. And so they're calling they're calling for guidance and so forth. So again, I just really, really want to get the assistance of our federal representatives on this line, is to push our Health and Human Services Secretary, our those leading the MPX rollout through the White House, really to push them to declare or to classify TPOXX under EUA. And I'll turn it over back to you, Jeff.
If I can respond to that one. So Henry, we are on the same page as you in terms of advocating for the changes in the test turnaround time, as well as for trying to get TPOXX more streamlined. So in fact, those were two major points in the Director Kim's testimony today, was that the tests are not only costly, but they're taking too long. And then similarly for treatment, when we're trying to facilitate treatment, us on the public health side are helping providers walk through some of this paperwork and trying to get them up and running, because we know that it's taxing the amount of paperwork. So if we could streamline that process and shift to an EUA, of course, that would help in the paperwork burden side of being able to streamline. But one thing that I did want to, I guess, mention in this, it's to make sure to call out, is that because of those long testing turnarounds, that's why we have come out saying that we should not wait for tests to come back before one, offering TPOXX. So healthcare providers should be evaluating if all the clinical picture matches. They should not delay and wait for the test to come back and lead to additional suffering. If this is something that they can look at, see that there was an exposure, if they can see that the rash is consistent, if they have a high clinical probability that this is TPOXX, that this is monkeypox, then they should go on and down the pathway of treating with TPOXX if the person meets criteria. So that's on the treatment side.
Yes, and if I may just, so yes, no, I completely agree with you. I mean, we treat empirically for a number of things. And so, yeah, it's a level of index of suspicion is high in the differential. Of course, we're going to initiate TPOXX, if it looks like it and there's a high level of suspicion, of course. My only concern is for potential for contact tracing, right? One of the things is that I do want to ask, how is, if my level of suspicion is high, I would still CMR, submit it to county. And then my follow-up question to the county is, what are the protocols in place for, we don't have a formal, an objective, lab-based diagnosis, but rather a high level of suspicion. Do you move forward with contact tracing and so forth, et cetera?
And I see Barbara has her hand up because she's probably also going to answer similarly, that at that point that we get information about a suspected case, we have had to shift to do earlier on contact tracing because of these lab delays. We can't wait on them. So Barbara, did you want to add on to that?
Yes, good evening, everyone. So rather than a CMR for reporting, what we're requesting is that the provider complete our intake form because it asks some of the key questions. Contact information for the contact. When we speak with the individual case, we also asked about contact. So we've tried to expedite that process to make it quicker. So if they're getting TPOXX, there's a reasonable index of suspicion that they have it, and we would proceed with at least the initial contact and see if we need to get other people in for post-exposure vaccination. Thank you.
Thank you, Dr. Cole. I do want to actually follow up on one aspect, is that for cases such as this, I would love to, and we would love to partner up with the county in a much closer way, in that reaching out immediately to your centralized nursing team and provide that information to you guys so that you can initiate that contact tracing and et cetera and so forth, and get as many of closest surrounding people to that infected individual or presumptively infected, is to get them in for vaccination, and kind of move forward on the preventative side as well. So I just kind of want to throw that out.
Yeah, that's definitely our aim. But what I'm hearing is that it sounds like we could streamline even better. And so we'll bring that back, look back at our work processes and see how we can expedite the referral over of the person, even if it's not the full case report form, but to see how we can make that go quicker and more streamlined, because that is exactly the aim, is that, provider reports it to us. We then do the contact tracing. We don't wait on the lab results, given that that's taking too long, and we want to get people vaccinated for post-exposure as needed as soon as we can. From what you were mentioning, it jogged my mind too of a couple of other things that we wanted to bring up and get feedback on. One of them was the use of MPX or MPVX versus monkeypox. So monkeypox has been framed as a potentially stigmatizing language. It is language that the federal government, the state government is still using in many counties. However, we did want to get some feedback in terms of when we're putting out materials, what your thoughts are about that language. So that's question number one. And question number two, just because and we can go to that one afterwards, is we're pulling together resources for people that have monkeypox, because of the isolation timeline. We're getting, finding out about people that might need help with laundry services or money for food or clothing, or, if people are taking off work, that means they're not getting money. And if they're not getting money, then they can't afford to live, essentially. So if people, and Jeff already provided me some resources, which is very helpful. So thank you. I wanted to bring it to the larger community too. If you know of other resources that we can help with referring people to, in addition to the ones that we already have, so we can have a section on our website dedicated to these resources that we can provide to people who are in that situation. So is a two-part. One is the language we use, and the second part is about the resources.
Yes, thank you so much for that. Yeah, I definitely, I've moved to the MPX category. I definitely favor that. But one of the things is that, when COVID hit, one of the things that kind of happened was FEMA allocated a large money for sort of a Meals on Wheels, Great Plates program to provide food and services to the elderly and those who are in need and unable to cook for themselves. One of the things I'm wondering if that's something that can be proposed also to either to FEMA or to other emergency response services, given that this has been declared a PHE, a public health emergency, is rolling out those additional funds for programs such as Great Plates or Meals on Wheels, and provide services for the community. And because you're asking people to or patients, individuals to isolate for 4 weeks, and it's not it's not a 7 day, 10-day isolation as we do with our COVID protocols. This is a much lengthier isolation period. And so to your point, I think getting members in the community and reaching out to FEMA might be also incredibly helpful as well. So thank you.
Thanks. And then one other thing that I just wanted to comment on is, so in what you were explaining, and I know what you meant by it in terms of the spread of potential to kids or to pregnant women. And one of the things that I fear is that it should be enough that it's in the LGBTI community. It shouldn't have to spread to any other community for it to be important. And so I wanted to voice that because I wanted to be clear that in the communities that it's presenting in right now, that's a huge problem. And it shouldn't have to go anywhere else for it to be elevated to be a problem or for it to be considered at a higher level. We have 70 cases in the county. That's, you know, part of the reason that we declared the public health emergency. And so I just wanted to explicitly say that that is enough, and that is concerning, and that is exactly why we need to mobilize, despite where it does or does not spread from there.
Absolutely. Thank you for that. Appreciate it.
Thank you. Dr. Ritchie has her hand up, and then Dr. Stapleton.
Yeah, hi. I have one more comment, and I was going to expand on Dr. Barber's comments that it seems like every city that I heard has different guidelines for who is to get vaccinated. For instance, today on the Senate hearings, I think it was Los Angeles that said anyone that had multiple anonymous partners within the past, I think, year were eligible for vaccine. And it makes sense to me. So are you moving in that direction? Because I think that's a really important part of the community that needs to get vaccinated.
We're sure hoping to be able to broaden that the category. I think once we find out more about the intradermal, that will greatly shape in the direction that we're able to go and how quickly we're able to move in that direction. But it's like I've said, and I know it's frustrating. It's frustrating to say, it's frustrating to hear, and it's frustrating to be in the position to say that we're having to make these really difficult calls based off of having a limited resource. It's not where we want to be, but it's a position that we're in, and they're having to make the tough calls. But yes, of course, we want to be moving in the direction of opening it up to those that have had multiple sex partners, among other risk factors that people self-identify.
Thank you. And fingers crossed that the new guidance on splitting the doses and doing them intradermally will give us the numbers we need to be able to do that. And David's proposal as well. So fingers crossed. Dr. Stapleton, go ahead.
Let me know if you can hear me okay. I am driving, unfortunately.
We can hear you.
So, okay, great, thanks. So I agree with those who commented that an emergency use authorization for TPOXX is needed immediately. And I'm wondering if you, Jeff, or any others on the call know of the channels and individuals at whom, I guess, and through which advocacy should be targeted. In other words, to whom should we be writing, calling? How do we get the feds to do this?
Yeah, there've been a number of kind of campaigns going on about this. So Javier Becerra, obviously, a little slow to act. He's not a public health official, but he seems to have finally gotten the message. Dimitri Daskalakis at CDC. I think FDA is now on board, so I think that's good. But I think the White House, from the top down, I would love them to see them put Dr. Fauci in charge of this if he has anything left in him after COVID. But yeah, I think we really need a top-down response from the very top level. So I think Raul Ruiz, being our congressman and a doctor himself, would probably be our best bet. And I don't see her on unless she joined in the last few minutes. I was looking to see. Often Aaron Doty from his office is on these calls. I don't see her on, but we can reach out to her and see if he's willing to take that up and maybe have him join a call maybe Thursday when the providers and the task force meet to do something.
Yeah, there's also head of the monkeypox task force. It was mentioned last time as a fellow named Bob Fenton, and so he should be contacted as well. I don't know how to get hold of Dr. Daskalakis anymore since he went to the CDC. I've written him 2 or 3 times, and he used to answer back and doesn't. So he might have a new email. Or maybe he's just really busy. I don't know.
Yeah, we can ask him. Let's see. But I think you're right. We have to do more politicking now. Anne, did you have anything else you wanted to say?
No, I think we just just not feasible to be doing all this paperwork that's required to maybe get TPOXX. It's just too much work, and I think they can still do their trials if they want to, and if they can't, well, too bad.
Yeah, and speaking of trials, the AIDS Clinical Trials Group is planning to do one. We can probably do that here because Eisenhower is a site for other ACD research. So I don't know how long that'll take. The ACDG is notoriously slow, but they did swing into action pretty quickly for COVID. So the hope is they can do that here, and we'll have that right here in Palm Springs. Dr. Barber, go ahead.
Just a question, and this may upset some people on here, but I don't have to bring it up. If anybody in the CDC has any information on, we know how long people quarantine until the lesion's resolved, but how long do people have to continue to wear condoms after they recover? Because as we know with Zika from 2 years ago, people could still be transmitting Zika up to several months after they recovered. And there's been several studies that have shown monkeypox in semen. There was actually a preliminary recommendation by the UK's version of the CDC that people after recovery from monkeypox continue to use condoms for 12 weeks. So do we have any data from the CDC as far as, is this just a positive test? Is it replicate competent virus that's present in the semen? Any studies being done to look and see how long do people need to be careful after they recover? Because we know as far as monkeypox, you isolate until all the lesions resolve. But what about if it is in the semen? How long does that persist for? And how long do people have to use condoms to protect their partners?
And yeah, vaginal fluids as well, right? So absolutely. These are all really good questions. And we are recording this so we can get those, and perhaps on Thursday's call talk more about how to advocate for that. I did want to allow time. We've got about 15 minutes left for each site to give an update on kind of what's happening on the ground for them. So Dr. Barber, before you go away, since Borrego is alphabetically first, did you want to talk about how many have gotten vaccinated, who you're vaccinating, and all that good stuff? You're muted. Sorry, go ahead. No need to unmute.
We've used up our initial allotment. We just received a new shipment today, so we'll be proceeding with that. And hopefully, if we do get some of this guidance as far as if we can do the intradermal shots, they give us 5 times the amount of doses we have. That'd be great. We could probably hopefully move forward and vaccinate everybody. So we've completed used our first allotment. We're into our second allotment now. And like I said, I would love to, if we said that one of the things is limiting things is trying to bring people in is because of the staffing and stuff. And like I said, if the county has nurses, as far as if you want to do a pop-up clinic, we could provide, probably, I can work to the medical director for Borrego, and we got clinics in Eastside, we have clinics in San Jacinto, we have clinics in Cathedral City, Desert Hot Springs, Coachella. We can set up a pop-up clinic if you want it, almost any of those locations. If you can provide the staff, we'll provide the locations.
Great, thank you for that. So currently, you're only vaccinating patients within your system then, who meet the.
No, we have had some from outside, but it's hard to do because we're trying to keep up with the patients. I have my regular staff to see. Now on top of that, trying to do all the reporting, the reports to the county for the suspected cases, reports to the CDC for the patients for TPOX and everything. I don't have the staff. And like I said, if we had staff, we could do a lot more. And we could bring people in. It's just we jump the staff to bring all these people in.
Great, thank you.
But we have had people from outside our clinic. Yes.
Great, thank you for that. So next up is DAP. I know Dr. Morris posted something earlier. I don't know if they want to add any more specifically about whom they're vaccinating now, if it's just their clinic patients, and what their current criteria are for vaccinating. I don't know if Trent was on earlier, or David Lee.
Looks like CJ may be on as well.
Oh yeah, CJ, if you want to unmute. Okay, we'll come back to DAP then. Eisenhower. Dr. Stapleton, if you want to. Did we lose her? I know she was driving.
To comment on vaccination, or
yeah, how you're vaccinating, how it's going at Eisenhower, if you're vaccinating just your own patients now or anybody else, and what the current criteria are.
Primarily our own patients at at risk as, and ideally post exposure prophylaxis early on, but honestly, a lot of it's really, whoever fills out, I guess, well, there's no form, but I'll just say that it's not fully, it's not entirely exactly as perhaps conceived, but and it's pretty much just we are using what we get and go from there, and so it doesn't feel very organized, but it's not because of us, it's because we don't know what we're going to get from the state. So it just keeps going beyond, this level and then the state, and so who knows. I know that sounds completely inarticulate, but that's how it feels.
Well, that's the situation, right? Not everything's terribly coherent these days. And then Kaiser, is anyone on for Kaiser? Last time we had Dr. Nasser on. And then is Desert Oasis, are they vaccinated yet? They've been added to the
They have begun vaccinating and supporting direct post-exposure prophylaxis referrals and their healthcare workers who are doing testing as they expanded to take on testing. I don't want to speak for anybody else who may be on from Desert Oasis, but that's the update that I have today. I believe that they've administered at least 20% of their allocation so far and are expanding into the risk profiles with referred patients from us, as well as their patient database.
Great, good to know. And I see Bob Holtz had posted a question in the chat asking if there's any update on the infection rates or complications among people living with HIV or older people.
Well, so I can say that there has been more literature put out around those with HIV and monkeypox. I posted a couple of those links in the chat. The one that was specifically delved a little bit more was a recent MMWR put out by the CDC. So that would be the one that I suggest to take a look at. So it, I guess that's where I'll start with it, is that there does seem to be the potential of increased severity of illness with people with HIV. And that's why there's additional research being done in that area. As might have been imagined or thought, those that have low CD4 counts or that aren't on antiretrovirals, it's thought that there are more the potential for more complications. And so the guidance that they talk through on there as well is, so if somebody is identified as having an HIV at the same time as that they are identified as having monkeypox, starting them on antiretroviral therapy at the same time that they're also doing the monkeypox treatment can help both with, of course, the HIV, but then also with potentially the progression of monkeypox too. So it lays out multiple different scenarios. So that's what I would suggest to take a look at.
You're on mute, Jeff. You're on mute, Jeff.
Sorry, I was going to say Dr. Morris is able to speak, has audio connectivity, as do I now. And so he's going to chime in with what's happening on the ground at DAP. Go ahead.
Hey, Jeff, can you hear me now?
Yes, we can. Thank you.
Yeah, so DAP has given about 670 vaccines. We had a sort of a volunteer vaccine clinic this weekend on Saturday from 7:30 to about 2 o'clock. And we gave out 162 this weekend. We still have a call list of over 650 of our highest priority patients. And we're expecting to get and hoping to get more vaccines this coming Friday. So we're already out this week. As of Tuesday, we're out of all of our vaccines, and we're doing the vaccines every afternoon for at least 4 hours.
Oh, wow. Great, thank you. So I see Dr. Barber's hand up, or go back down. Okay. Any other questions? Let me check the chat. Okay, great. So I think we've been on through all the providers with their updates on what's on the ground. Any other updates from the folks at the county or the state that they wanted to add? or any other questions? Yeah, Dr. Ritchie, go ahead.
Yeah, I just have one last question. Are any of the the places you give vaccines, or any of them? Because at the beginning of this, Dr. Chavinsky, you said that they should not be limiting them to their own patients. It sounds like that's really not happening. So, I mean, you know, are any of them offering to outside patients, or is that just not a possibility? And, you know, just wait for dividing the doses, or even then, I don't know if that's a possibility. It's, you know, these people that fall in the cracks, and I keep mentioning them, like our patients, you know, just aren't getting vaccinated. And that's, you know, sad.
So I can start on a response to that. And then I know there's providers on the call that might be able to speak as well directly about that question. As you heard from Borrego Health, that they are vaccinating a few that don't, or some number that aren't specifically seeking Borrego Health. It is true that all of our sites that we're encouraging and when signing on and with starting the vaccine process, it was not intended to be just those locations. I think what happened is that scheduling out in terms of identifying the patients and being able to put them on a schedule for vaccinating, that happened more quickly to be able to identify those that are within their own system that meet the criteria. And so that's it happened as an effect of being able to easily identify those people through their electronic health records. At the same time, we've tried to also supplement that by some of our clinics that vaccinate high-risk individuals that have been the information given to us by community partners and some of the people here on the call that have said that these are high-risk individuals that these are individuals that are at high risk that we are aware of. And so to aid in vaccinating them. And then the third part to that is the vaccine interest form. That was part of the reason that was started as well, is so that way we have another pool of people that are able to enter and that we can then fit into open vaccine slots as well. With that said, I know that there's still challenges with access that we're working on. And I do hope that with the shift to intradermal and with having more doses, it will allow us to be even more open in that way in terms of getting more people in. But we do have, we have been talking through plans on how we're going to be shifting people off of that vaccine interest form into an actual clinic where they would get vaccinated. So those plans are very much underway. But I do hear your frustration, and I also recognize your offer in terms of having PS test as a potential vaccine clinic. If you're not able to do it, or if the paperwork or the care process is proving challenging, that space is made available to us similarly in Borrego. So we appreciate that. And we're going to keep trying to push forward to broaden the access as we can. But I hear what you're saying.
Yeah, if you're looking at the chat, there's a lot of comments about how breaking it, if you're not part of these closed networks, you're kind of out of luck. And of course that exacerbates the inequity issues that we're seeing here. And we see in every pandemic, right? It's part of the problem with our healthcare system as it is. So being able to address that. And then of course, David's proposal directly addresses that. So hopefully we can make that happen. Kim, go ahead.
Yeah, thanks, Jeff. Just a couple of things. One, I just wanted to mention that we are working, I know that we've had lots of questions about kind of a breakdown of the data of our cases, getting into where jurisdictions are, all of the different demographic questions. And so I just want to reassure the group that we are continuing to look at that. The main reason that we haven't released it yet is just because we want to make sure that we are not compromising anybody's identity. And so I think that we are very close to being able to release some additional information on these cases. In the near future, we're kind of going over the last minute look at what a dashboard may look like. So hopefully by either tomorrow or next week, we'll be able to have additional information. And then the other thing I just wanted to mention briefly, I saw some comments in the chat about kind of comparing us to Los Angeles. And while I don't like to compare health departments, I do have to point out the fact that LA's had 43,000 doses of vaccine, while the whole state of California has had 66,000. So to make that kind of a comparison is really tough, because we've had, 4,600. So we're like a tenth of the vaccine that LA has had. Now we can argue all day about the wrongs of that, but just looking at the pure numbers, there has to be some grace when you're looking at comparisons between us and LA County.
Yeah, and it's LA got theirs directly from the CDC. They didn't have to go through the state because of such a large LA, New York, some of the largest jurisdictions got that. And you're right, it raises questions. Well, I guess bottom line, don't feel guilty if you drive to LA to get your shot there. Dr. Ritchie, I see your hand up.
I'm sorry. I just had one last thing to say. Kim, I just thought you were terrific at the state Senate hearings today, and I commend you. You were right on, and I hope they heard you. I just want,
Yes!
you just were wonderful.
Thank you. I appreciate that. But as I put in the chat, my talking points were taken from all of you, because you guys raise up the highest priority issues. And so, I was just happy to be able to voice that. So thank you, Dr. Ritchie.
Great, thank you. Thank you both, because you both presented there, and good to get our concerns heard. And Palm Springs is very well represented. I think we acquitted ourselves admirably there. We're the majority of people there. More of us than people from San Francisco, which is saying something. One last question, probably for Kim. Every time we ask about surveillance, and especially wastewater surveillance, any progress on that front?
Yeah, I haven't heard of any updates. I don't know if Dr. C has, but Palm Springs is still, as far as I know, working through kind of the algorithm of how to translate the wastewater loads to number of infected individuals. So I can check in with them and try to have an update for Thursday.
That'd be great, thank you. Great, well, we're almost at the end of our time. Any other last questions or comments? We'll call it a night. If not, thank you, everyone. We really appreciate you taking time out of your evenings, especially our hardworking public health officials and frontline providers. Makes for a very long day. So we appreciate doing all that we do, and
Jeff?
we can from help. But yeah, Gary, go ahead.
Yeah, I asked whether we know about the efficacy of a first full dose in terms of when it actually starts protecting against the virus, and what is the percent chance of being completely effective.
I can start on that one. We don't have great data for one dose, because the way that it was tested is it is a 2-dose series. It's thought that it takes a couple weeks for any one dose to reach a more full effectiveness. So around 2 weeks in plus would be where you would start to get more of the protection from the initial dose. But I also want to make it clear that having one dose is not what the studies have been based on in terms of full protection. So it might provide some level of protection, but not the full level of protection of 80+% that is considered after 2 weeks after a 2-dose series. And I think that is a really important question and point that you brought up, because that's part of the one of the things that we're thinking through as we plan vaccine events prior to perhaps large gatherings is that we don't want to give a false sense of security that you had your one dose, tomorrow is the event, and you're safe. That's all a messaging thing. That doesn't stop us from going in that direction. It's just we might need your help to message that, we're getting there with the protection, but it's not full protection yet after one dose.
Thank you very much.
One another level of uncertainty about that is we know what the data takes into account people who've already had a smallpox vaccination on board, but presumably they have somewhat better protection after the first dose. But do we know?
I do not know. I haven't seen data of somebody who had a smallpox vaccine and then one dose and then what the level of their protection is, but I can go back and reference literature and see if I can find anything.
Yeah, it's a question because we're an older community here, so many of us have had smallpox, so it's a question that keeps coming up. Terrific. Well, thank you, everyone. So these community town halls we're going to be doing every other Tuesday, going forward, at least until things change, just like we did with COVID. And then the providers and community health officials will be meeting every Thursday. So we'll be convening again in a couple days. So thank you, everyone. Appreciate all your input, and we'll be talking soon. Have a wonderful evening.
Thank you.
A great evening, everyone.
Thanks, everybody.